Disclosure, I don't have that any disclosure because obstetricians don't really get that much of it. Okay. Very rapidly, the three objectives of the antiretroviral therapy in the pregnancy setting, of course, is long-term health of the woman, and that's important for the mom and also for the baby, of course, to prevent sexual transmission, and that's the concept of safe conception on TASP, and to prevent perinatal transmission and have a healthy baby. So, of course, the objective is to have long-term antiretroviral therapy for all women. Perinatal HIV transmission is not an old story, but it's a success story because, as you can see in this slide, the rate of transmission of HIV-1 from mother to child has sharply decreased over the years with antiretroviral therapy in France and all European countries and throughout the world, as long as therapy is available. And the transmission rate in the last decade or so is about 3 per 1,000 in the French cohort, which is less than a dozen children per year. We can actually have zero transmission. We know that if antiretroviral therapy is used before pregnancy and during pregnancy with undetectable viral load throughout, there's no transmission at all. And the problem is, of course, that we still have a few cases of residual transmission. That's because of issues with adherence and access to care. It's also the issue, and basically the iceberg issue, which is how many women are infected during pregnancy, the incident infections with women who don't know they're HIV, they know they're HIV negative, but they don't know that their partner is HIV positive. Sometimes he knows, sometimes he does not know. So the issue of screening, testing is fundamental for women who are infected and for women to avoid being infected, also screening the future fathers. I often like to say that the PMTCT, the prevention of mother-child transmission issue, is a model of all the types of prevention that have been used over the years. But just a quick background. Most transmission, if we don't have therapy, most transmission occurs late in pregnancy and intrapartum. There's very little first trimester transmission, if at all, or in breastfeeding, during the breastfeeding period, if the baby is breastfed. And the issue of prevention is, of course, using antiretrovirals during pregnancy. And that's why I say, basically, that's what we've been doing long before TASP was shown to be effective for sexual transmission. We found that it was effective to prevent mother-child transmission. The same thing for intrapartum prophylaxis and the issue of PrEP, because we've been giving antiretroviral therapy to moms, nevirapine at delivery, AZT infusion, and just antiretroviral therapy, which will cross the placenta and prevent transmission to the baby. That's PrEP. And that's been used for years in the pregnancy model. Now, we don't really need PrEP as much as we did before, or even post-exposure prophylaxis, when the mother has received optimal therapy throughout pregnancy. And then, of course, there's a very big issue about breastfeeding, which means that women in places where breastfeeding is absolutely necessary will be on therapy and reduce the risk of transmission during breastfeeding, or the baby can receive prolonged prophylaxis. So basically, in our countries, the paradigm shift has been enormous from trying to prevent transmission to trying to use long-term therapy in the best possible way for optimal safety for the baby in terms of the risk of malformations, but also fetal toxicity, and we'll go into that issue. And it's the issue of these HIV-exposed, uninfected children who are very numerous. There's thousands of them in Europe and hundreds of thousands in the world. It's also the safety for the mother, the issue of adverse pregnancy outcomes, which has emerged as an important problem, and how to use antiretroviral drugs in the setting where the pharmacokinetics changes because of the physiology of pregnancy. And there's also an important issue for us as, in perinatal medicine, of course, is how to manage women who have optimal viral load suppression in labor and delivery, and should we do anything special because they're HIV positive anymore. So first of all, as far as the benefit-risk issue is concerned, there's one thing I would really say not to do, is what has been done in France, is to put a label on the box on the drug boxes to say, be careful in pregnancy, it's a dangerous drug for pregnant women. And 60% of drugs are considered dangerous, and it's up to the drug companies to decide whether they consider that it's a risk or not. And we have to tell our patients their guidelines, what we're giving you is something we've really thought about and discussed, and don't look at the box. That's a big problem. Because to say there's absolute safety is something practically impossible, and you can always pull out a study that showed that there was some type of side effect which may be true and may not be true. So saying that this type of approach, saying you just don't use anything, of course, is impossible. And to just say we'll not study the drugs and wait until there are hundreds of pregnancies, say with a drug that was not really recommended, and see what happens, and then we'll say, okay, maybe it was safe. And that means taking people for guinea pigs, which is not a good way to do it either. So I would definitely say we have to have good research. So the pharmacological issues, first of all, is the placental transfer of antiretrovirals. And as you can see on this slide, which kind of summarizes the data in the literature, there's differing placental transfer according to the different drugs. Mostly the nucleosides have good transfer. I don't know if I can use this. No, I'll never be able to do it. In blue, and the protease inhibitors, which are what we've been using for years in France the most, have less placental transfer, but they do cross the placenta to some extent and expose the fetus. And as far as the integrase inhibitors, the transfer is a little bit higher. There's only one drug that doesn't cross the placenta at all, which is T20. So that's an issue. The issue of fetal exposure, is it a good thing or a bad thing? Of course, if you have complete viral suppression in the mom, you might want to avoid placental transfer of the drug. And on the other hand, if you have poor suppression in the mom or late presenters, you want to have a very strong PrEP, and therefore you want placental transfer. So that will depend. As far as the maternal PK issues, there are a lot of them. I just wanted to mention a few of them. Of course, the drug metabolism and volume of distribution is modified by pregnancy. And we know that most of the PIs will have reduced plasma concentrations in the third trimester. That doesn't really mean that there's a reduced exposure to the fetus because the plasma proteins decrease, and therefore the free concentration can still be up there. But we do need to be careful. For example, darunavir has to be used twice daily in the third trimester because of pharmacological issues, and raltegravir twice a day too. I'm sorry, it's not T, it's B, ID, also, and not once a day. There's also an issue with the cobicistat boosted regimens, which, especially with elvitegravir, which can be underdosed and should be avoided for that reason. And then there are a few interaction issues, and the one that's still maybe a problem is with atazanavir and protease pump inhibitors, and also an issue of dolutegravir and nevirapine interaction, which could reduce the potential for last-minute intrapartum prophylaxis. And we're going to mention the important issue of late presenters and what to use intrapartum if nothing has been done before. And the last issue, which we don't know anything about today, is what's going to happen with the long-acting antiretroviral therapies when women become pregnant and they had an injection a few weeks or a few months ago. So what are actually the risks of these in utero antiretroviral exposures for the HEU infants? There's a lot of data out there, and I just wanted to say that the strong data, of course, concerns the older drugs. And we know a whole lot about zidovudine and the side effects of zidovudine for the infant. And of course, we don't know anything about the integrase inhibitors, say potential fetal toxicities. There's still controversy, but the malformative issue is probably not the major issue, although, as you know, there's a question about dolutegravir. I'll go back into that. But there are a few, say, signals concerning malformations, including with zidovudine, in fact, in the French cohort. There's hematological toxicities. There's the issue of mitochondrial disease, including some irreversible cases which we reported. There's myocardial dysfunction, which has been shown in infants, and even in fetuses. There's a Spanish group that has done fetal ultrasound and so forth. The bone density with TDF, which is kind of an issue that the results have changed over time. But basically, the big worry about these antiretroviral nucleosides is their interaction with nuclear and mitochondrial DNA, which could be associated with genotoxicity and possibly with an increased risk of cancer. And that whole issue goes back to what we just saw in the previous talk regarding senescence and so forth. Fortunately, the only drug which has been associated with postnatal increase in cancer is DDI, which we don't use anymore. But AZT and tenofovir have been associated with markers of genotoxicity in cord blood samples. So there's been this big issue about dolutegravir, which, as you, I think, may know, in Botswana, there was a follow-up of infants exposed to antiretroviral drugs. So it started actually because of the concern about efavirenz being related to neural tube defects in the monkey. And there was some clinical data, in fact, from the French cohort in particular, which is kind of worrying. And the Botswana study was a follow-up, the Tsepano study, of children exposed to antiretrovirals, and especially efavirenz-based antiretrovirals. And what happened is when they moved on to dolutegravir, they found a practically tenfold increase in neural tube defects in infants exposed to dolutegravir compared to efavirenz and compared to controls. Now that was only on 400 infants, and the follow-up study is underway, and everybody's holding their breaths because the results on the 1,000 following children who were exposed before the alert will be available by this summer. And on the right side is the modeling of how many cases. If you have no more cases in the next 1,000 kids, then basically dolutegravir will be off the hook. But if there's 2 more cases, then we'll say that it's probably a real concern. So as you know, we've been avoiding dolutegravir at conception. And the issue is that you have to really be careful. This means dolutegravir at the time of conception and at the time of the first trimester, and not necessarily later in pregnancy. So the malformative issue is important too. The adverse pregnancy outcome issue is something of very great concern, because you're exposing thousands and tens of thousands of pregnancies to these drugs, and we all expected that treating moms would make them healthier and we'd have better obstetrical outcomes, of course. But that's not really what happened. And what happened is that we saw adverse outcomes abnormally frequent in treated women receiving antiretroviral therapy, suppressive antiretroviral therapy. And one of the questions is, what's the control group? If you're controlling with women who are HIV uninfected, there are enormous biases. If you control with women who were treated with monotherapy in the previous period, then there's less of a treatment bias. And what we found in France is that the preterm delivery rate is twice as high as in the general population. And it's also twice as high as it was way back in the 90s, in the early 90s, when we didn't have all the active antiretroviral therapies. And there are many, many meta-analyses and cohort studies that have shown these same results. Not all of them, but most of them have shown that there's an increase in preterm birth. Some studies, but that's more controversial, have also shown an increase in intrauterine growth restriction and other adverse events. There's one very major study, which was the Promis study, which was randomized between simple AZT and triple therapy, which did show an increase in adverse events, including fetal and neonatal death, but also preterm delivery. And we were kind of skeptical about these results, although it was from a randomized trial, because there were so many different other risk factors which were not accounted for. And there's a recent study which showed that even when accounting for all of these demographic and clinical characteristics, there's a significant increase in adverse outcomes, especially in preterm delivery and very preterm delivery. So why do we have these adverse outcomes? Is it just confounders? Is it an issue of when the therapy was started? Is it an issue of spontaneous preterm delivery or medically indicated when you have an IUGR baby or a preeclampsia or something and you need to deliver the baby earlier? What are the mechanisms? There was a discussion about inflammation, and the inflammation issue is very interesting. There's a lot of work on that, possibly modified immune status, vascular changes, lipid changes, steroids. There's research showing that there's an increase in estrogen and lower progesterone level in women treated with ART. And there's even trials, 2 trials that are ongoing on progesterone supplementation to try to decrease these adverse pregnancy outcomes using progesterone. So it's a very challenging issue, and we really don't know. And especially, we don't know concretely what to do about it, because is it related to specific antiretrovirals, or is it just the concept of treating the mom and the, say, latent inflammatory issue, which can have an incidence on pregnancy outcomes, but also on the long-term health of the baby. And that's something which I don't know if you're very familiar with, but the intrauterine environment is very related to epigenetic modifications, which are very important for future health in the child. So basically, what do we know? Not much. Is it related to the PI boost? Is it related to tenofovir in the impact study, the Promis study, excuse me? Is it related to the PIs or not? We don't know. So it's difficult to really make guidelines based on that issue today, except to follow up the women. As far as the maternal toxicities, there's one that we're very aware about, is elevated liver enzymes. And we have evidence that this is related to the drugs, but also to pregnancy. There's an interaction between pregnancy and the antiretroviral drugs as far as elevated liver enzymes is concerned. Now be careful, elevated liver enzymes is something very common, and if we follow up these women, it's 15%, 2% severe. This is data from the French cohort. And in most cases, we don't know what it's due to. In some cases, we can find it's pregnancy-related, preeclampsia, cholestasis, and so forth. But in the unknown cases, that means it could be drug toxicity, and if you don't have any other drugs, it could be the antiretrovirals, and not necessarily one class as opposed to another, because we can have that with all of the drugs, and that can have an impact on pregnancy outcome, of course. So from a practical point of view, what ART should we be using? As in all fields of HIV therapy, of course, there's been a shift from protease-based treatment or NNRTI-based in some countries. It depends. France, for instance, we mostly use protease inhibitor-based therapy for many years. That's the case also in the US, much less in some other countries throughout the world where efavirenz was widely used. But the guidelines are now kind of starting to move, but based on very little data. I'll just share a little bit of the data with you. But one of the interesting things is that all of the guidelines that I've gone into, the French ones and the US, British, and the EACS guidelines, all recommend a nucleoside backbone, usually with TDF-FTC or with ABC-FTC. 3TC, excuse me. And of course, that's something, the issue we have with nucleosides is that's where most of the toxicity for the fetus in pregnancy has really been described. So nobody really has a way out for the time being of this nucleoside backbone. And as far as the drug to be associated, the first choice in France is still protease, and excuse me, I think that raltegravir as an alternative, efavirenz, and in some other countries, including in the European guidelines, basically they'll have an equivalence now between the integrase inhibitors, except for elvategravir because of the dosage issue that I mentioned earlier. Now, to say, are there really medications that are contraindicated in pregnancy? There aren't that many. There are older ones, of course, DDI, D4T, and so forth, nevirapine initiation, but nobody initiates nevirapine anymore. So basically, the only issue today is the dolutegravir issue, and the jury's still out on that one. But the difficult thing is when you have just insufficient data. Is it the same thing to say we have an alert for some possible toxicity, or should we just avoid the new drugs that we don't know much about? And from a, say, perinatal perspective, that's something which usually happens for, new hypertension drug or diabetes drug or antibiotic and so forth. And you kind of want to say, shouldn't it be the same for antiretroviral drugs to wait for good data and for studies to be performed before using them in pregnancy? And that's something which is a difficult issue in practice. Why? Because the classical scenarios for what type of circumstances antiretroviral therapy is going to be used in. And you have, of course, women who are not on therapy, and that's the easy one. You can choose whatever you decide in your guidelines. Of course, you'll adapt it to the resistance testing, especially in antiretroviral experienced women, because you have some women who will take the therapy during pregnancy and then just kind of disappear and come back. And of course, you can't just start with therapy without checking. And then you'll have the issue of women who are on therapy. And of course, if it's not well tolerated or if it's not suppressive, then you know what to do. To change it. But if it's well tolerated and virologically suppressive, should we adapt it to the current guidelines and say, well, no, we'd be very careful and try to avoid the new drugs if we don't know much about them? And that's a very difficult issue. Also, it's even better to do that before, when women are planning for pregnancy. If they do plan for pregnancy, and in the French guidelines we say that all people, including men, women, who are followed up for their HIV infection, should receive pre-pregnancy counseling, even at all ages, but I'm not talking about people who can have children. And then there's the issue of late presenters. So the treatment change issue is very important. And if you look at the data from our cohort, the timing of the first treatment change, first of all, most women did not change therapy at all, at any time during pregnancy. And there's a big part of the switches that occur in the first trimester in women who were on therapy, and we decided that that was not the best therapy and switched it. And that's something which I wanted to deal with because it's a little controversial. And then there are all the women who switched later in pregnancy because the therapy was not well tolerated or was not suppressive. So should we consider switching in the first trimester? So for example, with the dolutegravir issue, that kind of focused people's attention on the fact that periconceptional exposure means exposure at the time of the neural tube closure, which is 1 month post-conception, in other words, 6 weeks gestational age. And is it when you've reached 6 weeks gestational age, should we still be concerned? Or is that a pre-pregnancy issue? And the jury's out on that too, because fetal toxicities can occur with other drugs throughout development. And if there's a neural toxicity issue, it could be a malformative issue, but also a developmental issue. And that's something we saw with the valproic acid problem very clearly. Also, is there a risk of viral rebound if we do decide that we have to switch, independently of the reason for switching, just for concern about the fetal toxicity? The data from the French cohort is relatively reassuring. Actually, we published that recently because we did not find that there was more viral rebound when therapy was switched because of concern over the drugs in the first trimester, but there was good follow-up, monthly follow-up of viral load in the moms. And finally, there's the issue of late presenters. And that's more of a big issue for obstetricians, of course. And the third trimester, what's late? I mean, late is maybe, is it 5 o'clock on Friday? Is it third trimester, and of course, it's different if it's at 28 weeks, but be careful because as I said, you could have preterm delivery, and even at 28 weeks, the pregnancy could be terminated very soon. So the idea is to intensify therapy when there's late presenters, and there's another issue, of course, of intrapartum, when the mother has her HIV detected by screening at delivery, and you can use all of the drugs that have been used in the past, plus C-section, and intensive post-exposure prophylaxis in the baby. And that was why I mentioned the issue of the interaction between nevirapine and dolutegravir earlier. So now there's data, good data that's out, randomized trial presented at the CROI by Murashnik that shows that raltegravir does shorten the time to undetectability and increase the proportion of undetectability compared to efavirenz. They never compared it to what we use as protease inhibitors. And there's also the data, extraordinary data from the Dolphin-2 study presented at the CROI, which shows that there's a much more rapid decline in viral load with dolutegravir versus efavirenz. And there's going to be another much larger study which is ongoing on that issue. So basically, we can use these integrase inhibitors, and we recommend them for late presenters. So to summarize the multidisciplinary care for HIV-infected women, the best thing is to have good preconception care, and I hope everybody's convinced about that. And if the woman is not on antiretroviral therapy, to get her treated as early as possible. If the screening tests, if the woman's not on therapy, we'll start and monitor the tolerance, but also the efficacy. And there was an issue of whether monthly screening for viral load, which we do in France, is very helpful. There's some data, and in fact, there's an interesting study from South Africa that showed from the Cape Town, which showed that monitoring viral load improved the level of undetectability in pregnant women. And there's an important time, which is for multidisciplinary meetings to decide on the mode of delivery and the, whether treatment needs to be intensified and the type of prophylaxis in the baby. The French guidelines and most guidelines will say that if you have undetectable viral load, vaginal delivery without zidivudine is possible. If the viral load is poorly controlled, we'll offer elective cesarean with intrapartum zidivudine. If it's in between, we'll try to optimize and intensify and also optimize the adherence and get to the delivery with a low viral load, and offer postpartum prophylaxis to the baby, postnatal prophylaxis with zidivudine or nevirapine if the baby's not breastfed. In case of poor control or very late presenters, intensified therapy in the mother, C-section, and intensified therapy in the baby. So there was, of course, a lot of special cases and so forth, which I'm not going to deal with, but one point which was mentioned earlier in this morning was using less drugs. And that's something when I mentioned the issue with nucleoside analogs, and we've been very keen in France on trying to do away with nucleoside analogs, or at least reduce them, so use one instead of two, or maybe not use any. But there's very little data for the time being. That means using double, that means monotherapy, PI monotherapy, which is, of course, reserved for a select subgroup of patients. And there was one trial which was performed, and now there's a trial underway right now called Monogest, which is, in fact, the last enrollment was today. And so we'll have results in the next 9 months on this specific issue. So in conclusion, the idea is to eliminate mother-to-child transmission with minimal toxicity for the pregnancy and for the baby. Of course, that means screening, that means testing, that means starting ART early, that means multidisciplinary care. That's why, really, I think that's the take-home message. The problem today is that a lot of these women have, say, twice a year, their regular doctor's visit, and there's very little communication in a lot of places between the obstetrical and perinatal team and the HIV providers. And that's something which is very dangerous, because we have women who come in to delivery rooms in some maternities throughout Europe, and the people in the maternity don't even know what type of therapy the mom is taking, and if her viral load is undetectable. How can they tailor obstetrical care to that situation? So there's still a big research agenda, of course, to get these best options out there. And I think in the future, we'd really love to have a drug or an option which would have minimal transmission minimal placental transfer and maximal viral suppression. I don't know if that's going to be possible someday. So I'd like to thank all my colleagues in the French perinatal cohort and all the people throughout France who enrolled, the women, of course, in the cohort, and thank you for your attention.